As kidney function decrease, the accumulation of metabolic waste products and excessive electrolytes can significantly impair the health of patients with chronic kidney disease. As nutritional management of patients with chronic kidney disease is thought to control symptoms and has beneficial effects on the progression of kidney dysfunction, the diet of patients with chronic kidney disease should be an important consideration in their care. Many scientific evidences recommend limiting protein intake as high-protein diets aggravate kidney dysfunction. A high-protein diet, defined as intake of greater than 1.2 gram protein per kilogram of body weight per day, has been shown to cause significant deterioration in kidney function. High protein intake increases kidney blood flow and elevates intraglomerular pressure, which leads to higher glomerular filtration rate and more efficient excretion of protein-derived nitrogen products. High-protein diet-induced glomerular hyperfiltration may have deleterious consequences on the kidney and other organs in the long term. Several studies have shown that long-term exposure to a high-protein diet may cause kidney damage and progressive kidney dysfunction. A low-protein diet may preserve kidney function by decreasing kidney capillary hypertension and glomerular hyperfiltration. Protein restriction can decrease glomerular sclerosis, reduce proteinuria, and preserve glomerular filtration. Moreover, dietary protein restriction may improve metabolic dysfunction in chronic kidney disease. A low-protein diet may improve metabolic acidosis in patients with chronic kidney disease. Acid is produced by metabolism of proteins. As kidney function declines, there is a tendency toward impairment of acid secretion, which results in chronic metabolic acidosis. Metabolic acidosis impairs protein metabolism, increases muscle catabolism, and aggravates chronic kidney disease symptoms. Dietary modification is essential in the management of hyperphosphatemia in patients with chronic kidney disease, because dietary protein, especially animal protein, is a major source of phosphorus. Dietary protein restriction may be beneficial for control of hyperphosphatemia, which results in better control of chronic kidney disease mineral bone diseases. The major concerns associated with low-protein diets in clinical practice are the risk of protein energy wasting. A diet consisting of 0.6 to 0.8 gram per kilogram of body weight per day protein with adequate energy intake, 30 to 35 kilocalorie per kilogram of body weight per day, may satisfy dietary needs in patients with chronic kidney diseases, especially if half of the protein is from sources with high biological value protein containing the essential amino acids in appropriate ratios and amounts, such as eggs, milk, meat, and fish. Higher protein intake, 1.0 to 1.2 gram per kilogram of body weight per day, is recommended for patients with chronic kidney disease with replacement therapy, as additional protein is needed to prevent protein energy wasting. High sodium intake has deleterious effects on blood pressure, cardiovascular health, kidney function, and chronic kidney disease progression. In patients with chronic kidney disease, dietary sodium restriction is strongly recommended to control fluid retention, lower blood pressure, and reduce cardiovascular risk. Studies showed that sodium restriction resulted in reduction of blood pressure, extracellular fluid volume, and proteinuria in patients with moderate to severe chronic kidney disease. In addition, sodium restriction enhanced the beneficial effects of a low-protein diet, suggesting that sodium restriction may decrease proteinuria and slow the progression of chronic kidney disease. It is recommended lowering sodium intake to 2 to 2.3 gram per day in adults. Given the risk of hyponatremia and adverse outcomes, dietary sodium intake less than 1.5 gram per day is not recommended for patients with advanced chronic kidney disease as well as patients on dialysis. As the main intracellular cation, potassium mediates intracellular electrophysiology and plays an important role in vascular and neuromuscular functions. Serum potassium levels are finely regulated, as low potassium is associated with muscle weakness and hypertension, whereas high potassium can result in ventricular arrhythmia and death. Nevertheless, limited data are available supporting the idea that dietary potassium restriction improves the outcomes of patients with chronic kidney disease, and most recommendations are based on opinions. In addition to kidney function and dietary intake, several other factors affect serum potassium levels, including the use of medications, hydration status, acid-base status, glycemic control, adrenal function, catabolic state, and gastrointestinal problems, such as diarrhea, constipation, and bleeding. As there has been limited research on the effects of these factors, an individualized approach for each patient is recommended.
Phosphorus is an
essential nutrient for maintaining homeostasis and is found in most natural and processed foods.
phosphorus intake is necessary for bone growth and mineralization, as well as
for regulation of energy and acid-base homeostasis. Patients with chronic kidney disease typically maintain normal serum phosphorus levels during the early stages of the disease by promoting phosphorus excretion with increased fibroblast growth factor and parathyroid hormone levels. However, as CKD progresses, elevated serum phosphate levels or hyperphosphatemia may occur due to resistance to fibroblast growth factor and parathyroid hormone. Elevated serum phosphorus levels have been associated with increased cardiovascular risk in patients with CKD and in the general population. Hyperphosphatemia can cause left ventricular hypertrophy and arterial stiffness via induction of fibroblast growth factor and vascular calcification. Studies suggest maintaining a phosphorus intake of 800 to 1000 mg per day in patients with CKD to keep the serum
phosphate level within the normal range. Restricting the intake of animal-based dietary phosphates and replacement with plant-derived dietary phosphate may be considered.
To reduce the pill burden of phosphate binders in patients with advanced CKD.
Calcium is an electrolyte and multivalent cation that is essential for many bodily functions.
It is necessary for the functioning of muscles as well as the circulatory and digestive system, and is essential for bone formation and blood cell synthesis.
Calcium balance is strictly regulated by calcium absorption in the intestine, reabsorption in the kidney, and exchange in the bones.
Given the important role of the kidneys in calcium balance, the serum calcium level decreases as CKD progresses. Calcium level reduction can cause secondary hyperparathyroidism, which leads to bone mineral diseases, whereas extraosseous calcification resulting from excess calcium can lead to cardiovascular disease and increased mortality. Maintaining a balanced serum calcium level in patients with CKD requires consideration of several factors, including kidney function, mineral-controlling hormones, bone turnover, use of vitamin D analogs, and calcium intake from supplements.
Therefore, ensuring adequate dietary calcium is challenging and depends on unique factors affecting each patient's calcium balance.
In addition to dietary intake, vitamin D is also affected by the degree of sunlight exposure in seasonal changes, making it difficult to establish dietary standards. Vitamin D supplement regimens should be individualized, and serum calcium, phosphorus, and vitamin D levels should be measured periodically, especially in patients taking calcium-containing phosphate binders and/or active vitamin D analogs.
Thanks for watching.